Speaking of, there we go. The process of having the rules revised and completely redone started a while ago, and they are in concert with the strategic priorities for the Department of Health. And there are five strategic priorities, the winnable battles that we've identified: integrating physical and behavioral health services, promote and protect public health and safety, strengthen statewide public health system, and then maximize our effectiveness as a Department of Health. The item that's driving the change in the rules is the integration of the physical and behavioral health services. And we are getting toward the end, and we're in the process of integrating that physically. Our surveyors will no longer have a behavioral health licensing office. Now they are integrated, as are the rules. And you'll see that as we go through the rules, that some of the additions are specific to behavioral health. The purpose, some of the goals we had when we started going through this process, and what the legislature had directed us to do on or before July 1 of 2013, that was to reduce the monetary or regulatory costs on persons or individuals, streamline the regulation process, and facilitate licensure of integrated health programs that provide both behavioral health and physical health services. Those new integrated rules are in 9 AAC, which is the Administrative Code Arizona 10. We'll focus on health and safety first, providing regulatory consistency for all healthcare institutions. And you'll see that across the board. Some of these things that have been put in one set of rules will look very much the same in another set of rules for a different type of provider. Streamlining the regulatory process, integrating the behavioral and physical health services, and making changes delineated in our 5-year review reports. Those new rules, the integration plan is the facility will be licensed based on the highest level of services. So if it's a behavioral health, originally licensed as a behavioral health facility, and they want to integrate medical into that, they will still be licensed in that manner, but with the integration of the physical component of it too, and vice versa. All the medical services will be provided under the direction of a physician for any type of facility. All the nursing services will be provided under the direction of a registered nurse. All behavioral health services will be provided under the direction of a licensed behavioral health professional. And all behavioral health technicians and behavioral health paraprofessionals will receive supervision or clinical oversight from a licensed behavioral health professional. Our timeline is that the rules were filed with the Secretary of State on June the 28th, and now we have implementation starting as of October 1, and I'm sure you all realize that, otherwise you probably wouldn't be here. What does that mean for you? That means you need to start following the rules on October 1, as we said, and those rules provide facilities with more flexibility for policies and procedures. You'll see that listed in the rules over and over. Those rules speak more to the facility, identifying the types of skills, experience necessary for a particular type of practitioner or provider, and that will be in your policies and procedures as opposed to the state being prescriptive about that. We will look to that in your policy and procedures, and we will see if you are following your own policies and procedures. The staffing will be described in your own policies, procedures, and training. For more information, you can visit the website, which is adzhs.gov/ALS/integrated. And by the way, if you didn't pick them up, there are some small cards over on the table too that have the website there. So it looks like a little business card. You can take those with you. Sorry. You also find on the website what you have here, and it is a crosswalk of the rules and where you will find different items, and you'll see that on the website. That's another resource you can find there. R910 Article 6, what has changed? When we review each of these rules, you'll see that the rule content has changed in some cases. Definitions are definitely in a different place now. They have a different address. The definitions are in Article 1, which is the general article. And then at additions, we will have some information, some rules that we did not have before. And then interpretation and the article numbers, where you will find them, is in a different article now. The foundation for the rules is the law, it's the Arizona Revised Statute. And based on the law, the Arizona Administrative Code comes from that, and the rules are in that administrative code. And we will move on to the actual rules themselves. As we mentioned, the foundation for the rules is the Arizona Revised Statutes. Stop. I'm sorry, but that screen looks like it's wrinkled. Can you see okay? I haven't even looked at that one. From the side, it looks very much on that side. There's a little sketch there. I mentioned Article 1 before. It's the general, it's called the general article, and it has some general rules that apply across the board to all types of providers. So we have the definitions. Many of the definitions that were previously in the hospice rules are now found there in the definitions in Article 1, as well as the requirements for the different healthcare institutions, licensure exceptions, architectural review, all of those things. That some of those pieces of these used to be in separate rules. Now they are all in the general article, Article 1. The areas in Article 1 that are new are enforcement actions, which is Article 1, and it's R9, 10, 111, 110, I'm sorry. Tuberculosis screening is also in Article 1. And then you will see that the last several, 3 of the last 4 items have to do with behavioral health. The paraprofessionals, behavioral health technicians, then nutrition and feeding assistant training programs is the next to the last new one, and counseling facilities, as well as collaborative healthcare institutions. Now we come to Article 6, which will be the article that you have most interest in, which is the is for a hospice. And you can see that we have a number of sections in Article 6. It starts with definitions, and it goes through supplemental application requirements, etc. We will go through each of those sections one at a time as we go through. I just wanted to give you an overview as we start. As we mentioned before, the provider's responsibility as of October 1 is to review the rules, to understand those rules, and to be able to demonstrate your compliance with those rules. Definitions are in Arizona Administrative Code, Article 1, as I mentioned before, and some that are in Article 2. And we have references in many places to the Arizona Revised Statute. So, and I've highlighted, you can see the little bit of highlighting at the bottom there. When we come to those ARS, Arizona Revised Statutes, I've highlighted those so that you can be aware of those. I would encourage you to look those up on the website. You can find those on AZLEG, I believe, isn't it, Connie? For the statutes.
Actually, what has happened now is that when you go online and you go into the website, you can out there and you click on hospices, and it will pull up the unofficial version of the rules. We've attached hyperlinks to all the statutes.
Oh, okay.
If you click on the statute language there, it will automatically go over to the statutory requirement. So this went up there today.
So that's why I didn't know about that. So yeah, as she said, just so I can, so you can hear on the mic, and as he's recording, if I were looking at this on the website and I clicked on the ARS 36401, there's a hyperlink, so that you can actually look at the referenced ARS that is there. Okay, in hospices, Article 6 for definitions. Whereas you had a list of definitions prior, now there are only two that are listed in hospice rules that are specific to hospice. And that is the medical social services, which means activities that assist a patient or the patient's family to cope with the concerns about the patient's illness, finances, or the personal issues that may include problem-solving interventions and the identification of resources to address the patient or the patient's family's concern. Also palliative care, which means medical services or nursing services provided to a patient that is not curative and is designed for pain control or symptom management. And those are the only definitions that we have listed in the rules presently, for the new rules. In R910-602, the next section, which is supplemental application requirements, there's nothing really new in there. That's all what you've already previously been doing, so I won't spend time reading that to you. Under the next section is, which is 603, administration. The items that we have changed the color or highlighted there are the items that are new, or the verbiage has been changed sufficiently enough that we're bringing your attention to that. In administration, a governing body shall consist of one or more individuals responsible for the organization, operation, and administration of the hospice, and that governing authority shall establish in writing a hospice scope of services, qualifications for an administrator, and also designate an administrator in writing who has those qualifications that were established as identified there in number 2. And if you remember, the previous rules gave you some of those requirements that the state prescribed to you. Now it is up to the governing authority to make that identify those qualifications, and then designate an administrator who has those qualifications. Number 5 is also new: review and evaluate the effectiveness of the quality management program at least every 12 months. Number 6, designate an acting administrator in writing who has the qualifications established in subsection A2B, which is what we just read previously. If the administrator is expected not to be present at a hospice service agency's administrative office for more than 30 calendar days, or on a hospice inpatient facility's premises for more than 30 calendar days, or is not present at a hospice services agency's administrative office for more than 30 calendar days, or on a hospice inpatient facility's premises for more than 30 calendar days. Number 7, except as described in subsection A6, notifying the department according to the Arizona Revised Statute when there is a change in the administrator, and provide the name and qualifications of that new administrator. And here we have that revised statute that shows here, and that if you were to click on that when you're on the website, that would be what it would take you to. That an administrator is directly accountable to the governing authority of the hospice for daily operation of the hospice and services provided by or through that hospice. I have the authority and responsibility to manage the hospice. And number 3 is, except as provided in subsection A6, shall designate in writing an individual who is responsible for services provided by the hospice service agency when the administrator is not present at the hospice services agency administrative office, or inpatient hospice facility when the administrator is not on inpatient hospice facilities premises, and designate a personnel member to provide direction to volunteers. Another area that is new under the administrator is that administrator shall document and implement policies and procedures that establish. And here we begin a list of policies and procedures that we would expect you to have to give structure to the way you do business. Policies and procedures established that cover job descriptions, duties, and qualifications, including required skills, knowledge, and education, as well as experience for personnel members, employees, volunteers, and students. Covers orientation and in-service education for personnel members, employees, volunteers, and students, and includes how a personnel member may submit a complaint relating to patient care. Include a method to identify a patient to ensure that the patient receives hospice services as ordered. Also, those policies and procedures should cover patient rights, including assisting a patient who does not speak English or who has disability to become aware of patient's rights. Cover specific steps and deadlines for a patient to file a complaint and the hospice service agency to respond and resolve that patient's complaint. Policies and procedures should cover health care directives, medical records, including electronic medical records, a quality management program, including incident reports and reporting and documentation, and cover contracted services. Policies and procedures for hospice services are established, documented, and implemented that cover patient screening, admission, transport, transfer, discharge planning, and discharge. They also cover the provision of hospice services, and when general consent and informed consent are required, as well as covering dispensing, administering, and disposing of medication. Those policies should also cover infection control and telemedicine if applicable. The next few items, number 3 and number 4, are not new. They were previously in your other rules. Number 5 is there need to be policies and procedures. Those policies and procedures we just talked about should be available to the personnel members, employees, volunteers, and students. Unless otherwise designated, documentation required by this article is provided to the department within 2 hours after the department request, and when documentation or information is required by this chapter to be submitted on behalf of the hospice, that documentation or information is provided to the unit in the department, that is the Department of Health, that is responsible for licensing and monitoring the hospice. The next section we will look at is 604, which is quality management. I know that in the prior rules that did speak to quality management, these are the things that are added to those rules with this new set of rules. That quality management plan is established, documented, implemented for an ongoing quality management program that at a minimum includes, and these are the things that are new, a method to identify, document, and evaluate incidences, a method to collect data to evaluate services provided to those patients, a method to evaluate the data collected to identify a concern about the delivery of services related to patient care, a method to make changes or take action as a result of the identification of a concern about the delivery of services related to patient care, and the frequency of submitting a documented report required in subsection 2 to the governing authority. Item number 2, there should be a documented report that is submitted to the governing authority that includes an identification of each concern about delivery of care of services related to patient care, and any change made or action taken as a result of the identification of the concern about the delivery of services related to patient care. And that report required in subsection 2 and the supporting documentation for that report are maintained for 12 months after the date the report is submitted to the governing authority. The next section is 605, which is contracted services, and that entire section is new for hospice. An administrator shall ensure that contracted services are provided according to the requirements in this article, and a documented list of current contracted services is maintained that includes a description of the contracted services provided. Section 606 is personnel, and some of the new areas is that the qualification, skills, and knowledge required for each type of personnel member are based on I, the acuity of the patients receiving physical health services or behavioral health services from the personnel member according to the established job description. And that they include, and once again, these are item I and item I are already in your rules. The only thing that's been added is the behavioral health component. Under III, the type and duration of experience that may allow the personnel member to acquire specific skills and knowledge for the personnel member to provide the expected physical health services or behavioral health services listed in the established job description. The part that is new in the next item, which is number 2, is that the personnel member's skills and knowledge are verified and documented before the personnel member provides physical health services or behavioral health services. The next new item is under number 4, and that's orientation occurs within the first week of providing hospice services, and it includes informing personnel about department rules for licensing and regulating hospices and where rules may be obtained, and then reviewing the process by which a personnel member may submit a complaint about patient care to a hospice. And C was previously in the rules, providing the information required by hospice rules, by hospice own policies and procedures. Number 5, personnel receive in-service education according to criteria established in the hospice's policies and procedures. Number 6, inpatient education documentation for a personnel member includes A, the subject matter, B, the date of the in-service education, and C, the signature, stamp, rubber stamp, or electronic signature code for each individual who participated in that in-service education. Number 7, a personnel member or an employee or a volunteer who has direct interaction with the patient provides evidence of freedom from infectious tuberculosis as specified in R 910-112. Then an administrator shall ensure that a personnel record for each personnel member, employee, volunteer, or student will include documentation, and the first item under 3A is the individual's qualifications including skills, knowledge applicable to the individual's job duties, and the individual's education and experience applicable to the individual's job duties. And that information is maintained throughout the individual's period of providing services in or for the hospice. That's number 4, A, and then B, for at least 2 years after the last date the individual provided services in or for the hospice. And for an individual who has not worked in the hospice during the previous 12 months is provided to the department within 72 hours after the department's request. Next item is 607. This has to do with admissions. Before admitting an individual as a patient, an administrator shall obtain, of course, the name, which is already in the rules, and documentation, number 2, that the individual has a diagnosis by a physician that indicates that the individual has a specific progressive, normally irreversible disease that is likely to cause the individual's death in 6 months or less. Now, the last item under admission that is new is before or at the time of admission. A social worker shall assess the social and psychological needs of a patient's family, if applicable. The next item is under 608, which is transfer, and I believe that's an entirely new section for you. Transfer, except for a transfer of a patient due to an emergency. An administrator shall ensure that a personnel member coordinates the transfer and the services provided to the patient. According to the policies and procedures, an evaluation of the patient is conducted before that transfer. Medical records, including orders that are in effect at the time of the transfer, are provided to the receiving health care institution, and a personnel member explains the risks and benefits of the transfer to the patient or the patient's representative. And documentation in the patient's medical record also will include communication with an individual at the receiving healthcare institution, the date and time of the transfer, as well as the mode of transportation and, if applicable, a personnel member accompanying that patient during the transfer. Section 609 has to do with patient rights. The previous rules already had fairly extensive rules, but we do have some additions that are items that have been added across the board to all provider types. The areas that have been added is administrators shall ensure that a patient is treated with dignity, respect, and consideration. A patient is not subjected to, and the first three items are things that are already listed in the rules. Abuse, neglect, exploitation. The new areas include coercion, manipulation, sexual abuse, sexual assault, seclusion, restraint, if not necessary to prevent imminent harm to self or others, as well as misappropriation of personal and private property by the hospice's personnel members, employees, volunteers, or students. And the patient or the patient's representative, except in an emergency, either consents to or refuses treatment, may refuse or withdraw consent for treatment before the treatment is initiated, and except in an emergency, is informed of the proposed treatment alternatives to the treatment, associated risks, and possible complications. And another couple of items that were added that are new to what you previously have is except as otherwise permitted by law and under E, the hospice provides written consent to the release of patients' medical records and financial records. And the patient has a right to receive treatment that supports and respects the patient's individuality, choices, strengths, and abilities. Number 5, to receive a referral from another healthcare institution, they have a right to receive that referral from another healthcare institution if the hospice inpatient facility is unable to provide physical health services or behavioral health services for that inpatient. The next section is 610, and that is medical records. The administrator shall ensure that a patient's medical record is established and maintained for each patient according to the Arizona Revised Statute listed here. And as I mentioned before, if you on the website, you'll be able to click on that, and it will give you the hyperlink, and you'll be able to see the actual Arizona Revised Statute. An entry in a patient's medical record is recorded only by a personnel member authorized by the policies and procedures to make that entry. That entry is also not changed to make an initial entry illegible. And an order, along with being dated when that order is entered into the patient's medical record, also is authenticated by the medical practitioner or behavioral health professional according to policies and procedures. If the order is a verbal order, authenticated by the medical practitioner issuing that order. If a rubber stamp signature or an electronic signature code is used to authenticate an order, the individual whose signature the stamp or electronic code represents is accountable for the use of that stamp or that electronic code. Number 5, a patient's medical record is available to a personnel member, medical practitioner, or behavioral health professional authorized by policies and procedures to access the patient's medical record. Information in a patient's medical record is disclosed to an individual not authorized under subsection A5 only if that written consent of a patient or the patient's representative or as permitted by law. Section B, if a hospice keeps patient medical records electronically, an administrator shall ensure that safeguards exist to prevent unauthorized access, and number 2, that the date and time of an entry in a patient's medical record is recorded by the internal clock of the computer. An administrator shall ensure that a patient's medical record contains, and as you can see in number 1, all of those things are already in the rule in number 2, but a new item that's been added is the name and telephone number of the patient's physician, and also the admitting diagnosis. Other things that we would expect the medical record to contain would be a copy of the patient's living will, healthcare power of attorney, or other healthcare directive if applicable, and assessment required in R910-607, as well as care plans, progress notes for each patient's contact, including the date of the patient contact, and the services that were provided, a description of the patient's condition, and instructions given to the patient or the patient's representative. Also include documentation of restraint or seclusion, if applicable, and documentation of contacts with the patient's physician by personnel member. Number 17, if applicable, the transfer documentation from a sending healthcare institution, as well as documentation of a medication administered to the patient that includes, and we have several things here, A, the date and time of the administration, B, the name, strength, dosage, and route of administration, and for a medication administered for pain when initially administered or when administered PRN, an assessment of that patient's pain before administering the medication and the effect of that medication that was administered. Then for a psychotropic medication, when initially administered or when administered PRN, an assessment of the patient's behavior before administering the psychotropic medication and the effect of the psychotropic medication that was administered. The identification should also be included with signature and professional designation of the individual administering or observing the self-administration of medication and any adverse reaction to a patient that has received that medication. The next item is 611, which is the care plan. And as you can see, the first section 1 and 2 were previously in your rules. It starts with number 3. That plan needs to include the patient's diagnosis, the patient's healthcare directives, the patient's cognitive awareness of self, location, and time, the patient's functional abilities and limitations, goals for pain control and symptom management, then not only the type but the duration and frequency of services to be provided to that patient, and then treatments as well as the treatments the patient is receiving from a healthcare institution or healthcare professional other than hospice, if applicable. Medications ordered for the patient, known allergies, nutritional requirements and preferences, as well as specific measures to improve the patient's safety and protect the patient against injury. And then under item C, number 2, a patient's care plan is reviewed and updated whenever there is a change in the patient's condition that indicates a need for a change in the type, duration, or frequency of the services that are being provided. And number 3, a patient's physician authenticates the care plan with a signature within 14 calendar days after the care plan is initially developed. That care plan would also include nutritional services, which is number 3 there, including a menu planning and designation of the kind and amount of food appropriate for that patient. And then medical social services provided as identified in the Arizona Revised Statutes that are identified there. And medical social services for other social services by an individual with a master's or higher degree in social work who has at least 1 year of social work experience in a healthcare setting, or by a licensed baccalaureate social worker according, again, to ARS 3291. Under B, in addition to the services specified in subsection A, an administrator of a hospice service agency will ensure that the following are included in the hospice service provided by the hospice. The new item here is respite care services. Under D, a medical director shall ensure that a patient's need for medical services is met according to the patient's care plan and the hospice scope of services. If a patient is receiving medical services not provided by or through the hospice, hospice services are coordinated with the physician providing medical services to the patient. A director of nursing shall ensure that a registered nurse or a practical nurse provides nursing services according to the hospice policies and procedures. The other items that the director of nursing is to ensure include: 4, a personnel member is only assigned to provide services the personnel member is only assigned to provide services the personnel member can competently perform. Number 5, a registered nurse assigns tasks in writing to a home health aide who is providing home health aide service to a patient, provides direction to that home health aide services provided to a patient, and verifies the competency of the home health aide in providing those assigned tasks. Registered nurse also has responsibility that the patient's physician is immediately informed of a change in the patient's condition that requires medical services. The next section is 613, which is medication services. And under that, we have an administrator shall ensure that the policies and procedures include, we have a long list here, a process for providing information to a patient about medication prescribed for the patient, including the prescribed medication's anticipated results, the prescribed medication's potential adverse reactions, potential side effects, and adverse reactions that could result from not taking that medication as prescribed. Procedures for preventing, responding to, and reporting an adverse response to a medication or a medication overdose. Procedures to ensure that a patient's medication regimen is reviewed by a medical practitioner and meets the patient's needs. Procedures for documenting medication services and assistance in the self-administration of medication. Procedures for assisting patients in obtaining medication. And if applicable, procedures for providing medication administration or assistance in the self-administration of medication off premises, and specify a process for review through the quality management program of a medication administration error and adverse reaction to a medication. If a hospice provides a medication administration, an administrator shall ensure that 1, policies and procedures for medication administration are reviewed and approved by the medical practitioner, that they specify individuals who may order medication and administer medication. They ensure that the medication is administered to a patient only as prescribed, and the patient's refusal to take prescribed medication is documented in the patient's medical record. Verbal orders for medication services are taken by a nurse unless otherwise provided by law. A medication administered to a patient is administered in compliance with an order and is documented in the patient's medical record. A pain medication is administered to a patient. Documentation in the patient's medical record includes an identification of the patient's pain before administration of that medication and the effect of that pain medication administered. If hospice provides assistance in self-administration of medication, an administrator shall ensure that a patient's medication is stored by the hospice and that the following assistance is provided to the patient. A reminder when it is time to take that medication. B, opening the medication container for the patient. C, observing the patient while the patient removes medication from the container. D, verifying that the medication taken is ordered by the patient's medical practitioner by confirming that the patient taking the medication is the individual stated on the medication container label. The dosage of the medication is the same as stated on the medication label, and the medication is being taken by the patient at the time stated on the medication container label, or observing the patient while the patient takes medication. Policies and procedures for assistance in the self-administration of medication are reviewed and approved by the medical practitioner, a pharmacist, or a registered nurse. Training for for personnel member other than medical practitioner or registered nurse in the self-administration of medication is provided by a medical practitioner or a registered nurse or an individual trained by the medical practitioner or a registered nurse. It includes demonstration of the personnel member's skills and knowledge necessary to provide assistance in self-administration of medication, identification of medication errors and medical emergencies related to medication that require emergency medical intervention, and the process for notifying the appropriate entities when an emergency medical intervention is needed. A personnel member or other than a medical practitioner or a registered nurse completes the training in subsection C4 before that personnel member provides assistance in self-administration of medication. And assistance with the self-administration of medication provided to a patient is in compliance with an order and is documented in the patient's medical record. An administrator shall ensure that a current drug reference guide is available for use by personnel members. A current toxicology reference guide is available for the use by the personnel members. Item 3, if pharmaceutical services are provided on the premises, a committee composed of at least a physician, one pharmacist, and other personnel members as determined by the hospice's policies and procedures is established to develop a drug formulary, update the drug formulary at least every 12 months, develop medication usage and medication substitution policies and procedures, and specify which medication and medication classifications are required to be automatically stopped after a specific time period unless the ordering physician or ordering medical staff member specifically orders otherwise. The pharmaceutical services are provided under the direction of a pharmacist. The pharmaceutical services comply with ARS Title 36, and you can see it's Chapter 27, Title 32, Chapter 18, and the Administrative Code 23. And a copy of the pharmacy license is provided to the department upon request. When medication is stored at a hospice inpatient facility, an administrator shall ensure that there is a separate room, closet, or self-contained unit used for medication storage and includes a lockable door. If a room or closet is used to store the medication, a locked cabinet or self-contained unit is used for medication storage. Medication is stored according to instructions on the medication container, and policies and procedures are established and documented and implemented for receiving, storing, inventorying, tracking, dispensing, and discarding medication, including expired medications. Discarding or returning prepackaged and sample medications to the manufacturer if the manufacturer requests the discard or return of medications. C, a medication recall and notification of patients who receive recalled medication, and D, storing, inventorying, and dispensing controlled substances. An administrator shall ensure that a personnel member immediately reports a medication error or a patient's adverse reaction to medication to the medical practitioner who ordered that medication, and if applicable, the hospice's director of nursing. The next section is 614, which is infection control. An administrator shall ensure that infection control is established under the direction of an individual qualified according to the hospice's policies and procedures to prevent development and transmission of infections and communicable diseases, including a method to identify and document infections, analysis of the types, causes, and spread of infections and communicable diseases, the development of corrective measures to minimize or prevent the spread of infections and communicable diseases. And documenting the infection control activities, including the documentation and analysis of infection control data, the actions taken relating to infectious and communicable diseases, and reports of communicable diseases to the governing authority and state and county health departments. Number 2, infection control documents are maintained for at least 2 years after the date of the documents. Item 3 is not new to you. It was in the rules previously, but one item under item 3, policies and procedures established, documented, and implemented. One of those rules is cleaning of an individual's hands. This is a little bit different verbiage than we had in the current rules. Cleaning of an individual's hands when the individual's hands are visibly soiled, and before and after providing a service to a patient. Then training of personnel members in infection control policies is added, as well as work restrictions for a personnel member with communicable disease or infectious or infected skin lesion. And that's all that is new in that section. The next section is the food services for a hospice inpatient unit or hospice inpatient facility. An administrator of a hospice inpatient facility shall ensure that a food menu is prepared. And you have a large area here that is new. That has to be prepared at least 1 week in advance. And it should include the foods to be served each day. It is conspicuously posted at least 1 day before the first meal on the food menu will be served. It includes any food substitution no later than the morning of the day of meal service with a food substitution, and is maintained for at least 60 calendar days after the last day included in the food menu. Meals and snacks are provided by the hospice inpatient facility are served according to posted menus. And number 3, meals for each day are planned using the applicable menu planning guides, and you will find there the government website that is to be used for program basic meals. Number 4, a patient requiring assistance to eat is provided with assistance that recognizes the patient's nutritional, physical, and social needs, including the use of adapted eating equipment or utensils. And water is available and accessible to patients at all times, unless otherwise stated in the patient's care plan. Under B3, that's the next item, food is prepared using methods that conserve nutritional value, flavor, and appearance, and B, in a form to meet the needs of the patient, such as cut, chopped, ground, pureed, or thickened, as we did. And then under the foods requiring cooking, we have requirements for temperatures that are more than what you have in your current rules. Those foods requiring cooking are cooked to heat all parts of the food to a temperature of at least 145 degrees Fahrenheit for 15 seconds. That's not new. But what is new is the identification that ground beef and ground meats are cooked to heat all parts of the food to at least 155 degrees Fahrenheit. Poultry stuffing, stuffed meats, and stuffing containing meat are cooked to heat all parts of the food to at least 165 degrees Fahrenheit. Pork and any food containing pork are cooked to heat all parts of that food to at least 155 degrees. Raw shelled eggs for immediate consumption are cooked to at least 145 degrees for 15 seconds, and any food containing raw shell eggs is cooked to heat all parts of that food to at least 155 degrees Fahrenheit. Roast beef and beef steak are cooked to an internal temperature of at least 155 degrees Fahrenheit, and leftovers are reheated to a temperature of at least 165 degrees Fahrenheit. These areas that are showing now are things that are already in the rules, nothing new there. And we come to the next section, which is section 616, the emergency and safety standards for hospice inpatient facilities. Emergency, but the emergency standards, as you can see, don't have change. The only item that is new is under number 2. The disaster plan required in section A1 is reviewed at least every 12 months. I believe the time frame is a little different than you have in the current rules. An evacuation plan, drill for employees is conducted on each shift at least once every 3 months. And documentation of each evacuation drill is created and maintained for at least 12 months again after the date of the evacuation drill. And that drill includes documentation of date, time, as well as the amount of time taken for the employees to evacuate a hospice inpatient facility. Under B, an administrator shall obtain a fire inspection conducted according to the time frame established by the local fire department or the state fire marshal. Number 2, that to make that any repairs or corrections stated on that fire inspection report and maintain the documentation of a current fire inspection. Next section is 617, and 617 is the environmental standards for a hospice inpatient facility. Administrator of a hospice inpatient facility shall ensure that policies and procedures are established, documented, and implemented that cover transport, storage, and cleaning of soiled linens and clothing, housekeeping procedures that ensure a clean environment, and isolation of a patient who may spread an infection. Next item has some new verbiage is under equipment. The equipment is used at the hospice inpatient facility is maintained in a working order. It's tested and calibrated according to the manufacturer's recommendation, or if there are no manufacturer's recommendations, as specified in the hospice inpatient facilities policies and procedures, and is used according to the manufacturer's recommendation. Documentation of equipment testing, calibration, and repair is maintained for at least 12 months after the date of the testing, calibration, or repair. Garbage and refuse are removed from the premises at least once a week. And soiled linen and clothing are collected in a manner to minimize or prevent contamination, and they are bagged at the site of use. For common areas, I mentioned the hospice itself, the cooling system for the heating and cooling systems maintain the hospice inpatient facility at a temperature between 70 and 84 degrees Fahrenheit at all times. And the common areas are lighted to ensure the safety of patients, and they have lighting sufficient to allow personnel members to monitor patient activity. Supply of hot and cold water is sufficient to meet the personnel hygiene needs of patients and the cleaning and sanitation requirements in this article. Oxygen containers are secured in an upright position. And number 13, if pets or animals are allowed in the hospice inpatient facility, pets or animals are A, controlled to prevent endangering the patients and to maintain sanitation. They are licensed consistent with local ordinances. They're vaccinated as follows. A dog is vaccinated against rabies and leptospirosis. A cat is vaccinated against rabies. Number 14, if a non-municipal water source is used, water source is tested at least once every 12 months for total coliform bacteria and fecal coliform or E. coli bacteria, and corrective action is taken to ensure the water is safe to drink. And documentation of testing is retained for 2 years after the date of the test. 15, if a non-municipal sewage system is used, the sewage system is in working order and is maintained according to all applicable laws and rules. And the next standard is, or the next section is 618, which is the physical plant standards for a hospice inpatient facility. The first area where we have some new verbiage is under B. B says an administrator of a hospice inpatient facility shall ensure the premises and equipment are sufficient to accommodate the services stated in the hospice inpatient facility scope of services and an individual accepted as a patient by the hospice inpatient facility. An administrator, C is an administrator of a hospice inpatient facility shall ensure that a patient's sleeping area, number 2, measures at least 80 square feet of floor space per patient, not including the closet. And 4, contains a door that opens into a hallway, common area, or outdoors. And as you can see, there are no changes in the following areas there that I'm scrolling through. Those are all in your current rules. And I'm thinking that it's just about the end of the rules. And as you can see, we mentioned Catherine McKenna is the branch manager. Connie Belden is our bureau chief. I'm a team leader, and Jean Roush, who is not in the room at the moment, is also team leader. Contact number to get a hold of any of us is 602-364-3030. And for the estate architects, that's Lois Adams, and there's Savita Chandagiri. Each of those, their email addresses are their first name dot last name, and for each of us, it's the same way, at azdhs.gov. Give me a minute to write those down. Okay. It shows here where you can access a read-only copy of the 2010 guidelines on this link only for preview, but not for printing or downloading. And that brings me to the end.